Hello, my name is Vashti Mapp. Currently, I work as an emergency room RN, in which I've been practicing for the past 7 years. Previously to this, I worked on a med tele floor and floated throughout the hospital to floors including ICU step down, oncology, ortho, um, and even cardiac care that specialized in step down from open hearts along with the cardiac ICU. The reason I'm giving you this background has to do with some of the knowledge that I'd like to impart according to my proposal. I am a DNP student that's specializing in adult gerontology critical care. Currently, my project proposal deals with the use of bedside ultrasound machines in code situations. Working in numerous hospitals as a travel RN, I've been privy to seeing how codes have been ran in different facilities, um, causing me to want to streamline codes in an effective manner. I know that we have the American Heart Association code algorithm, but even with that in place, I have seen codes that did not weren't effective, especially for patient outcome, and it could have been different. So, that being said, I believe that with the use of ultrasound machines at bedside in a code situation, that you're able to view the heart, what can be caused for the patient to have either no heart rate or pulseless PEA, I should say, pulseless electrical activity, along with either VFib or VTAC, that causes this arrhythmia that's detrimental to the patient and causes us to have to assist in their heart beating. So the ultrasound can help to decrease code times by showing if there's like a corrective action that can be taken in a more immediate manner, saying fluid around the heart that's causing the heart to not beat with a correct rhythm, or even showing why the heart is beating in a manner that's detrimental to the patient. Also, another reason to have effective use of the ultrasound machine at bedside is to also view with the carotid arteries how blood flow is going to the brain, because ultimately we want to make sure the patient has a good quality coming out of a code situation. It's shown that in hospital cardiac arrest, it's a major public health problem. The incidence of the in-hospital cardiac arrest has been reported in the range of 1 to 5 events per 1,000 hospital admissions. Reported survival rate, unfortunately, is not that great. It can vary from 0 to 42%, mostly within the range of 15 to 20%, according to Liu et al. From a 2011 study. Also, in a study conducted by the American Heart Association in 2013, the numbers really did not change much from this previous study. Unfortunately, those are some low numbers, and I'm hoping to incorporate my ultrasound machine use in code situations to possibly help increase those numbers. So my stakeholders would be you guys who I'm speaking with, the CEO, CFO, and CNO at the hospital. Value of the project is to increase the patient life expectancy and quality, also decrease the use of code times, and care which decreases time spent away from other patients by staff who are in the code situation. I tend to see when a code is called, and typically on the floor, even in the ER. In the ER, a lot of the nurses, they know their roles. In the hospital that we are at now, we have a code team, and they do come to the code situations. We do not call codes to the ER, so we call them on their phone, and they do come down to help assist in this code. So that helps to free up a couple nurses that are in the ER and to not have to be in that code situation, so they can take care of the other patients when the primary nurse and, say, another nurse, along with the code nurses, doctors, pharmacy, respiratory tech, the a couple of the EMTs or techs that we have in the ER are at bedside in this code. On the floor, however, the code nurses go to those codes along with their primary nurse and usually secondary nurse. And actually, sometimes they will have too many people in a room when it comes to codes on the floor, because they happen a little bit less than when you see them in the ER. So people can be a little bit rusty in how code should be ran. So I would also propose to have more education to the use of staff in a code situation when it comes to the floor. Now, so the value is shown by us having decreased times with better outcomes because of the use of the ultrasound machine, and being able to see how our compressions are working, along with what possibly could be causing this code or problems with the patient and the heart, or even if they're bleeding in different areas, say, which I have seen happened. So if we can find that pocket of fluid and then decide where to go from there. Also, a way in which you will be kept informed of the progress of how the use of the ultrasound machine at bedside in code situations are used would be about a monthly email to keep you in the loop of the progress that it's being done with, that shows the statistics associated with the time per code and resources used. Help and facilitation of this project. At this current time, this facility already has a good code situation with the code team that's in place. So it would just need to have education. They would just need to have education, increased education on the use of the ultrasound machine in the code situation and how we would want it used for this particular project, along with some formal education given to staff on floors for how the codes would work when the code nurses come to the floor, respond to the codes being called, along with the other staff that will show up. Also, the estimation of the cost, which is, I should have said in the value, would be little to nil, because most ERs actually have their own ultrasound machines that they use, and that cost is zero because it's not a cost that we use or we bill to patients. And also, sometimes there is an ultrasound machine that isn't in use anymore, so that can help to, we can either use another ultrasound machine just for dedicated to the code nurses, or we can find maybe a refurbished one. I'm sorry, not a refurbished one, but one that was maybe used as a takeaway for educational purposes that was not used, and be able to buy one. That would be a bedside one. So outcome measurement would be their survival rates. that we would be looking at for patients. So patient survival is linked to quality of cardiopulmonary resuscitation. When rescuers compress at a depth of less than 38 millimeters, survival to discharge ranges after out-of-hospital arrests are reduced by 30%. Similarly, when rescuers compress too slowly, return to spontaneous circulation after in-hospital cardiac arrest falls from 72% to 42%. So having the use of the ultrasound machine would help to increase those numbers, because we can immediately see, hey, we're not doing this correct. Let's get some better compressions in, along with finding cause, decreasing how much medication we're pumping into the patients. So it decreases their time spent in the hospital with return of spontaneous circulation. If there's any questions, feel free to ask me, email me. Other than that, thank you for listening to my proposal.